Good afternoon, everyone. Welcome to the second in our webinar series for palliative care services in RACHs. And today we're fortunate to have Cody presenting for us on pain and symptom management.
Hi, everyone.
Move to the next screen, Cody. Before we begin, I would like to acknowledge the traditional lands on which we are meeting today, the Wiradjuri country, and pay my respects to elders past, present, and extend recognition to all Aboriginal people reading this message. We respectfully acknowledge the Aboriginal nations in which we are meeting today, and we acknowledge the impact of elders and the knowledge as knowledge holders and teachers. Today I would like to welcome Cody Merritt. Cody is a clinical nurse specialist in palliative care. Cody has worked with the Western New South Wales LHD Specialist Palliative Care Team since 2022. Prior to this, Cody had an experience working in a number of settings, including rural nursing, emergency and aged care. Cody was born and raised in Condobolin, New South Wales, and has a strong connection to the Western New South Wales area. Cody is passionate about improving the quality of palliative care received by rural and regional patients in New South Wales. Welcome, Cody. Also on the screen, you may recognise Hayden Welsh, and I am Anne Burns, and we are both working with the aged and palliative care team with the Primary Health Network. So just a little bit of housekeeping. Today's presentation is for 30 minutes. There will be 15 minutes for questions at the end. You'll notice a Q&A tab on your ribbon at the top of your screen. You are able to type in questions in that space, and you can prioritise the questions by hitting the arrow up button under the question on the right-hand side of the tabs. Cody will answer as many questions as time permits at the end of the presentation. At the end of the presentation, you'll find an evaluation form by accessing the QR code. So it's with pleasure that I hand over to Cody, who will complete our presentation for today. Thank you.
Thanks, Anne. Thanks, everyone, for joining. It's a pleasure to be here today and present this webinar. So the learning guides for today's session are hopefully will increase your knowledge of basic symptom management for palliative care patients, will increase your knowledge of focused assessment of physical symptoms for palliative care patients, and will aim to build your confidence around supporting aged care residents and their families with symptoms associated with palliative illnesses. So I'll just run through a few different symptoms. We'll start with pain, and we'll just work our way along a few of the sort of more common symptoms that a lot of our palliative care patients do experience at some point in their journey. Pains are a very, very common symptom that a lot of our patients do experience, whether they've got some sort of oncology diagnosis or dementia or some sort of organ failure, or even just general aged and frail patients. Whenever we're trying to assess patient's pain, we've always need to do a comprehensive assessment, preferably using an established tool such as the PQRST mnemonic, or the Abbey Pain Scale for those who are not able to communicate, such as our dementia patients. So the PQRST mnemonic will look at the type of pain, the quality of the pain. So what does it feel like? Does the patient describe it? Does the pain radiate anywhere? How severe the pain is, and the time of onset of the pain. And whereas the Abbey Pain Scale looks at more of your non-verbal symptoms of pain, so body language, vocalization such as groaning, agitation, and things like that for the patients that are not necessarily able to voice that they've got pain. The reason that those sort of pain assessments are really important is the way that patients will describe pain often gives us a good understanding of what's causing that pain, and we can know sort of which medicines to try and tailor towards addressing that pain. So a good place to start with pain relief is often just simple analgesia, such as something like a paracetamol or ibuprofen. Most patients, unless they're allergic to these medicines or if they're contraindicated with whatever their medical history is, they should have something sort of simple charted that you could start with, whether that's just something like some paracetamol or something like a non-steroidal anti-inflammatory such as ibuprofen. If those medicines are ineffective, then often what we look at introducing is something stronger, such as an opioid painkiller. So some of the more common opioid painkillers that we see are things like oxycodone, morphine, and hydromorphone. These sorts of painkillers are often more tailored towards severe pain, or perhaps someone who has pain from something like a cancer or an oncology issue. These medicines seem to sort of better treat that type of pain. There's a few different types of opioids. So we've got our fast release opioids, which sort of work quickly and wear off quickly. So things like endone, or if it's a morphine-based medicine, it might be the oral morphine elixir. Ordine is a brand name of morphine elixir that we sometimes see. And then hydromorphone as well, which comes in tablets and injectable medicines. Whenever someone's got sort of increased pain, we always sort of need to be thinking, what's the reason for the increased pain? So perhaps somebody's constipated and they're not absorbing their regular analgesia. Perhaps if they're a patient with a known disease, perhaps there's been disease progression, or have they had a fall and injured themselves. So we've always got to consider what's the reason for the patient's increased pain. It's very, very important that when we're administering analgesia, that we always document the reason why we're administering the analgesia in the patient's notes. So whether that's for the type of pain, knee pain, back pain, and then the effect of the analgesia after administering. So this is really, really helpful for for the doctors that are looking after these patients, or even the palliative care team. If we're coming in to review patients, we'll know what sort of pain the patient's experiencing, why they're needing these medicines, and are they actually working when they take the medicines. When possible, we should always try and use oral analgesia as our first line for pain relief, as we don't sort of like to move on to things like injectable medicines unless we actually need them. We always try and go with the least invasive route possible first. So if someone's still able to tolerate oral medicines, there's no issues with their swallowing or no concerns with absorption, then we should be using the oral route. Some triggers for using injectable medicines obviously would be if perhaps patients aren't able to swallow anymore, whether that's because of a physical difficulty with swallowing, whether they're too drowsy to swallow, or maybe we're concerned with absorption. Perhaps they have something like a bowel obstruction and they're not going to absorb oral medicines. I won't sort of delve too much into the different types of painkillers, because I think we probably would be a bit pressed for time if we went too in depth. So we've talked about our opioids. We do have other sort of pain medicines out there for nerve pain. I might just touch on those briefly. So often if patients are sort of experiencing pain that is sort of more sharp and stabbing, or burning, shooting, pins and needles type pain, it's really important to document that, because they might need something like a neuropathic agent that works more on nerve type pain, something like a pregabalin or a gabapentin. But I won't sort of delve too deep into that today. Otherwise, I think we'll probably be too pressed for time. I might move on to breathlessness now, which is a very common symptom that's seen in a lot of our respiratory patients, and sometimes even some of our patients with an oncology diagnosis such as lung cancer. And it's often a really tricky symptom to manage. With breathlessness, we often try and use a range of different techniques for managing it, which include both pharmacological and non-pharmacological techniques. So some of the different medicines that we might try and use to manage breathlessness are opioids. We often see opioids prescribed for breathlessness, things like morphine, oxycodone, hydromorphone, and if there's an anxiety component that's sort of exacerbating the breathlessness, sometimes we might see benzodiazepine medicines such as lorazepam, diazepam, and clonazepam. Again, with the opioids, we're sort of looking at usually something immediate release versus something like an oral morphine elixir or an oxycodone elixir that sort of works quickly and then wears off quickly. If someone's sort of using a fair few regular doses of opioids, then sometimes we might look at starting a slow release version of those, often in a tablet form that sort of stretches out over either 24 hours or 12 hours, depending on the type of tablet. The current sort of best practice guidelines with managing breathlessness is actually shifting away from opioids, because there's sort of mixed evidence out there that they often don't work, is what a lot of the data is sort of suggesting now, and that a lot of breathlessness is sort of actually exacerbated by anxiety and agitation around becoming short of breath, and that the opioids sort of aren't as effective at managing that. So a lot of the current guidelines are shifting away from opioids. So when we're sort of talking about managing breathlessness with non-pharmacological techniques, what we should be looking at is first and foremost repositioning our patients. So how are they sitting? Are they sort of slumped low in bed, or leaning back in a recliner chair? If so, we should be repositioning them so they're sitting a little bit more upright and able to expand their lungs a bit better to get air in. Often patients who experience breathlessness regularly really respond well to the flow of air. So we can do things like opening windows, using fans for airflow. So whether that's a stand fan, or whether even a little handheld fan that the patient can hold themselves sort of in front of their nose, or just underneath their nose, and that flow of air can stimulate the nerves around the nose and mouth and help feel like they're getting more air in. If they've got quite tight clothing on, particularly around the neck, like buttons and things, and loosening those. Plenty of reassurance, and some breathing techniques as well, such as rectangle breathing, which I'm not sure if anyone's ever heard of that before, but it's where you get the patient to sort of think about a shape such as a rectangle. If they've got a mobile phone, a really good way of doing that is getting them to actually use the mobile phone. I don't know if you can see the one that I'm holding up, but get them to breathe around the phone as the rectangle. So take and actually trace it with their finger. So take a short breath in, and a long slow breath out, and a short breath in, and a long slow breath out, and just using the phone to trace around that. It gives them something to focus on, so that they're sort of focusing on the breathing and tracing around the rectangle. Just sort of moving further on, and still on the topic of breathlessness, a common symptom that's seen when palliative patients are sort of entering the terminal phase is respiratory secretions, or sort of gurgly breathing. It used to be called the death rattle, but I'm not particularly fond of that term. With respiratory secretions, the first and foremost, the most important thing to remember is that this is actually a very normal symptom that is observed in the terminal phase for palliative patients, usually in the last sort of 24 to 48 hours of life. when the evidence around it is a little bit sort of not 100%, but the current sort of theory is that as sort of people do move towards end of life, the muscles in the back of the throat, they relax a bit. They just don't swallow that saliva as well as they used to be able to, so it builds up and sounds quite gurgly. We can use medicines sometimes to manage these symptoms, such as glycopyrrolate or hyoscine, but there's actually limited evidence documented on the effectiveness of these medicines. Often where they work best is actually prior to the secretions starting. Once the secretions actually start, often the medicines, they've kind of missed that window where they're effective and don't tend to work. I tend not to recommend these medicines too often because sometimes they actually end up drying out the whole mouth cavity, the nose, the eyes, rather than actually working on the respiratory secretions, which the current evidence sort of suggests that patients can't actually feel those secretions. So I think that, if we're giving these medicines, sometimes we're causing a problem that they can actually feel to fix something that wasn't bothering them. So some non-pharmacological strategies that we use to manage respiratory secretions are things such as nursing the patient side to side to allow them to drain naturally, sometimes slightly elevating the head if they're in bed. One of the most important things is regular mouth care. So with a mouth swab and some Sodibic mouthwash, cleaning out the mouth cavity. Sometimes people will suction secretions, but we should actually be avoiding suctioning respiratory secretions, particularly deep suctioning down the back of the throat, and certainly avoiding suctioning the soft and hard palate of the mouth, because we don't want to cause any damage to those regions. If the secretions are particularly bad, then sometimes they do need suctioning, and if that's the case, we should just always be using the soft Y suction equipment, which is just like a soft plastic tube rather than the hard yanker suckers that you often see in emergency departments and theatres and things like that. Probably the most important thing to remember with respiratory secretions is providing education and reassurance to the family, because it's actually more distressing to the family than it is for the patient. So that's educating the families that this is actually a normal part of the dying process, that those muscles at the back of the throat have relaxed, the saliva is not draining away as well as it normally would, that this isn't actually distressing for their loved one, they can't feel that, and that we will manage it by nursing them side to side or regular mouth care, and that it's not causing any discomfort for their loved one. I'll move on now to nausea and vomiting, which is a particularly distressing symptom that a lot of our patients obviously can end up experiencing. With nausea and vomiting, it's always important to consider what's actually causing the nausea and vomiting. So is it related to their underlying palliative illness, such as a cancer or some sort of organ failure, or are they actually just unwell with a viral illness? Often these do spread quickly amongst residents when there is a viral illness going around. Another common cause of nausea and vomiting is actually constipation. If patients are quite constipated, then and they're not able to pass that stool, then they can feel nausea, or they can end up actually even vomiting. Especially patients that have developed a bowel obstruction, or is it a side effect from a medicine that they've started recently? Has there been a recent change in medicines that's sort of started just before the nausea and vomiting? So we use a variety of different medicines to manage nausea and vomiting. So things like metoclopramide is probably a really common medicine that you'll see used. Other medicines such as haloperidol and cyclizine are also used. And sometimes these are used either as an oral medicine or as a subcut. medicine. One indication sort of for using subcut medicines over oral medicines for nausea would be if someone does have very regular vomiting and they're not actually able to keep their oral tablets down, then we'll often use a subcut medicine rather than an oral medicine. Or if someone is really severely constipated or even has a bowel obstruction, then we would be using subcut medicines rather than oral medicines so that we know that they're absorbing. Ondansetron is often a really commonly prescribed medicine for nausea and vomiting in the community, but we actually prefer not to use ondansetron for palliative care patients, and the reason being so is that regular ondansetron use can actually increase the risk of constipation. The way it works is sort of by slowing down the bowel, and a lot of our palliative care patients are already on medicines such as opioids, which can already slow down the bowel. So we run the risk of increasing their risk of constipation, which in turn can increase their nausea and vomiting. And usually every patient will require a different treatment for nausea based on the underlying cause. If constipation is the cause, well, something like metoclopramide might be more beneficial because it actually increases the movement of the bowels, which may actually aid in resolving the constipation. But something like a bowel obstruction, well, metoclopramide wouldn't be appropriate because the bowel's obstructed, so you wouldn't want the muscles moving. Some other things to consider are a lot of antiemetics are not appropriate for Parkinson's patients because they can make those symptoms worse. So things like metoclopramide and haloperidol are actually contraindicated in Parkinson's patients. I'll sort of segue on from nausea and vomiting and talk about constipation and bowel management now. So all of our aged care residents should have a bowel chart attended at least daily and documented on whatever system you guys use for charting. With all of our patients, we aim for their bowels to be open daily to second daily. Obviously, in some of our patients that aren't eating and drinking as often, maybe they might sort of be open second daily to third daily, but we should still be aiming for sort of daily to second daily. Even if you're not eating regularly, your body will be producing waste, which does still need to be excreted. A really, really important thing to remember is that if a patient is charted an opioid, then we always must have a laxative charted as well. Whether that if they're on a regular opioid, so taking a tablet or whatever the opioid is regularly, they should have a regular laxative charted, because that can always be withheld if they don't need it. If someone has a PRN pain relief charted, nothing regular, then a PRN laxative will usually be sufficient to start with. A really, really good starting dose for a laxative would just be something simple like coloxyl and senna, 2 tablets of an evening, which can be increased to twice a day if needed. If patients' bowels aren't open for 3 days, then generally what we suggest in palliative care is we actually need to look at something like a microlaxanna or a glycerol suppository to try and move things from the bottom end as well as the top end. So certainly still continue the oral laxatives, but add in a microlaxanna or a glycerol suppository, which can actually be nurse initiated. Another thing to remember also is diarrhea. So not just constipation, but diarrhea can be a common symptom that's experienced by palliative care patients. So whether that could be related to their disease, their underlying disease. So perhaps if they've had some sort of bowel cancer and maybe had part of their bowel resected, then diarrhea might be an ongoing issue. Another really, really important thing to consider is with diarrhea is it actually diarrhea or is the patient constipated and having what we call overflow, which is where they're constipated and there is solid stool in their bowel, but they can't pass that, and all they can actually pass is the more mushy liquid stool around that. So sort of very, very important when someone is having diarrhea to look back through those bowel charts and find out what their bowels have been like prior to the diarrhea starting. If you're worried that someone is constipated, then certainly we should be performing an abdo assessment on the patient. So looking at their abdomen, their stomach, does it look normal, or does it look like it's distended and not sitting right? We should also have a listen with a stethoscope. So can you hear bowel sounds? Can you hear the bowel moving, or are you not hearing any noise when you're listening, or are the bowel sounds overactive? And also feeling. So what does their tummy feel like? Is it nice and soft, or is it quite firm and hard? And if it's firm and hard, then that's obviously a sign that they might be constipated. And also, is their tummy painful when we're touching it as well? And always good to do it in that order. So look, listen, and then feel, because sometimes if you're feeling first, then you can disrupt things and you might not necessarily get an accurate picture when looking at it or listening to it. And I'll just move on to agitation and anxiety as well, which is a really distressing symptom that often our palliative care patients can experience. So with agitation and anxiety, a little bit similar to some of the other symptoms that we've talked about, we always sort of need to be going back to and thinking about what's the underlying cause of the agitation and anxiety, what's changed for this patient that's causing this symptom. So some common symptoms that we might see are urinary retention. If someone's a known oncology patient, well, have they had disease that spread to their brain, such as brain mets or a brain tumor? Often in our patients that are sort of more confused at their baseline, such as dementia patients, well, perhaps they're in pain, and the way that they're responding to that is to be agitated or anxious. They're not necessarily able to express that I'm in pain. They're unwell and they don't feel right, but they're not able to express it properly. So we like to address anxiety and agitation through both pharmacological and non-pharmacological strategies. So some of the non-pharmacological techniques that we use are to address the patient's concerns. So if they are quite anxious, we'll try and sit with them and actually talk about what are you anxious about, what is bothering you, and try and address those underlying causes. So are they distressed because of their symptoms? Are they anxious because they have pain that's not well managed, or some other symptom? Are they worried about their disease? Are they worried about dying because they have a terminal illness? So addressing those underlying concerns, plenty of reassurance, sometimes distraction and music therapy often help as well. Some of the pharmacological medicines the techniques that we might use to manage anxiety are things like your benzodiazepam, such as lorazepam, diazepam, and clonazepam. Haloperidol is used as well. Sometimes if patients are agitated and they're sort of sitting in that terminal phase more closer to the end of their life, or they're not swallowing properly, then sometimes we might use midazolam. Some other sort of strategies to think about is that if the patient does have a dementia diagnosis, then sometimes a referral to Dementia Australia is actually really beneficial. They can often come and assess patients and help put in some management strategies that are a bit more tailored to that person to try and manage some of the agitation and anxiety. And if appropriate, we can also look at services such as older persons mental health, which the GP can refer the patient to try and work through some of that underlying anxiety, particularly if they have had a lot of mental health illnesses in the past as well. Then sometimes it's beneficial to get their expert opinion. I've actually kind of progressed through this a lot quicker than I thought I would. I thought this would take about half an hour, but it's sort of 15 minutes, and we've kind of reached the end of the slides, so which might probably leave a bit more time for questions if everyone's okay with that. I'll just point out with some of the references and resources that I've attached to the slides here, and Hayden might copy those into the chat so that you guys can access them, because they're really, really good resources. The first resource is the palliative and end-of-life model of care, which has been developed by the Western New South Wales PHN, which is a fantastic resource that they've put together. When I started this slide quite a while back now, this link worked, but it actually doesn't work at the moment. They're sort of changing where that sits on their website at the moment. So that link won't work, but the guys from the PHN will pass that on to you when that is up and working. Palliative Care Australia is a really, really good website where you can find a whole host of resources about palliative care and managing symptoms at all different stages. And I believe there's actually some aged care specific resources on there as well. And the Agency for Clinical Innovation is a New South Wales government website that's actually also quite beneficial. And that's a QR code which you can do at the end of the session to provide some feedback. But we might open it up to some questions now, seeing as we've progressed through it a little quicker than I thought we would.
Thanks, Cody. If people would want to put any questions they have for Cody in the chat, and Hayden will copy the link to those resources. As Cody mentioned, the EPAF model link is currently under redevelopment. We've had a change of our website and we're just reorganising where that will sit, but we will be promoting the EPAF model once it's in its new location through our aged care newsletter, which is a monthly newsletter which goes out to all of our RACHs, so you will have access to that. Please use your phone to get a copy of the QR code to answer the very quick and simple evaluation form. It is extremely helpful to us in planning this and future events. And yes, if anyone has any questions, just pop them in the Q&A or the chat. That would be great. Okay, well, on behalf of everyone here, I want to thank Cody for his presentation today. I certainly learned something and it was very interesting to listen, and a wonderful opportunity to learn from our local clinicians, and I hope that the participants found it helpful. Just for your information, this is part of a webinar series, so we will be holding our next event on the first Wednesday of the month in December, and then with a break in January, and then we'll be leading into the new year with a complete series. Again, we will be promoting these through our newsletter, and so you will be able to have access to those future registration opportunities. So on behalf of Western New South Wales Primary Health Network and Western New South Wales Local Health District, I'd like to thank you for attending today. Thank you.
Thank you.